Good morning, dear colleagues. We are starting now our second session for today. This is going to be about gyne-oncology. We have 4 speakers who are going to discuss the topic today. And please reminder, each presentation will last for 20 minutes to be followed by a question for 10 minutes. If you allow me to introduce my first speaker, Professor Farouk Koz. He works in Medipol Mega University Hospital as the chair of Obs and Gyne between 2014-2016. Currently, he is the chairperson of Obs and Gyne Department and Department of Oncology at Acıbadem University Atakent Hospital, Istanbul, Turkey. Today, he is going to talk about an update of the HPV vaccination. So please welcome Professor Koza.
Thank you, dear chairs and my colleagues. First of all, I want to thank, on behalf of organizing committee, my dear colleague Fatna Al-Khan for her kind invitation. And I want to present you the HPV vaccines. And first of all, I want to share with you expected burden of HPV-related diagnosis in the world. As you see here, almost 0.5 million cervical cancer cases and 10 million high-grade SAL related to oncogenic HPV types. And when we look at the low-grade SIL, 30 million cases with oncogenic and non-oncogenic HPV types, and genital warts, 30 million. Again, undiagnosed HPV infection, 300 million. One of the main causes of mortality in developing countries is cervical carcinoma. All women under risk, even screening programs are ongoing. These are the HPV serotypes in cervical carcinoma. As you know, HPV 16 and 18 is the most important 2 HPV types, and almost 71% of the cases with these 2 types. And when we look at the additional 5 types, for 7 HPV types, 88% of the cases developed from these 7 HPV types. Is there a difference between the continents? This is the HPV prevalence by type. As you see, there's no important difference between the continents. And do the genital warts lead a major health issue? Let's check it. More than 90% of anogenital warts are caused by 16 and 11, as you see here. And in the United States, sexual active women incidence is almost 1%, and lifelong risk is higher, and recurrence is important problem. This diagram shows us the importance of genital warts in England and Wales. As you see here, it's rising geometrically, and when we look at Turkey, this is one of the 2 published studies in genital warts epidemiology in Turkey. Annual prevalence in this study is 154 per 100,000 women, and recurrence rate is almost the same with the United States. And this is our publication, point prevalence adjusted to age, and as you see here, we found almost 4% of the cases has vital data in general population. After this brief introduction, I want to discuss you the HPV vaccines. And this is the graphic. It shows us implementations of the countries who has HPV vaccine in their national implementation program. And as you see here, all of the countries, developed countries, and this map shows the disturbance between these 2 problems, and these countries has a very important cervical cancer problem, and these green countries has HPV vaccination in their national implementation program. We know there are 3 HPV vaccines. Bivalent vaccine contains HPV 16 and 18 virus-like proteins, and quadrivalent vaccine, additional 6 and 11 for the anogenital warts, and nonavalent vaccine contains 6 and 11 for anogenital warts, and additional 7 high-risk HPV types. These are the adjuvants. All the adjuvants includes aluminum and aluminum hydroxide, as you see. When we look at the aluminum adjuvant, hepatitis B vaccine contains almost the same amount, 0.5 milligram dose for adults, like nonavalent vaccine. And we used a hepatitis B vaccine for 25 years safely. In Feature 3 trial, initial assessment shows us 16 and 18 positivity, only 1%. Because of that, before the vaccination, cervical smear or HPV testing or serotyping is not necessary. These are the FDA and EMA approvals. As you know, bivalent vaccine, no approval for the males, for FDA and EMA again, and FDA approval between 9 to 25 years, and EMA no limits, upper limits for all 3 HPV vaccines. This is an important 10-year data of countries with quadrivalent HPV vaccine in the national program. When we look at the details of this presentation, decrease in HPV 6, 11, 16, and 18 infection, 90%, as we expected. And decrease in genital wart rate in men and women, again, 90%, as we expected. When we look at the decrease in low-grade cervical cytologic abnormalities, only 45%. Why? Because the other part of the non-oncogenic HPV types can be the cause of the low-grade cervical cytologic abnormalities. The most important thing is decreasing in histologically documented high-grade cervical cytologic abnormalities, and it is very good response, 85% decreasing. And this is an interesting study presented at ASCO 2000 meeting, and girls and boys who received at least 1 dose of quadrivalent vaccine, prevalence decreased by 88.2%. It is very important. And we have a systematic review and meta-analysis about the effectiveness of prophylactic vaccines. As you see here, CAN2 plus associated with HPV 16 favors vaccine, and again, HPV 18 favors vaccine. These are the meta-analyses. Why a nonavalent vaccine has been designed? We have bivalent vaccine, quadrivalent vaccine, because remember again, when we look these 4 types, 6, 11, 16, and 18, for cervical cancer, vulvar cancer, vaginal cancer, anal cancer, high-grade cervical precancers, and genital warts, 70% to 90%, but with 9 types, almost 90% for all of these HPV-related problems. Quadrivalent vaccine has demonstrated some herd and cross protection. Is it necessary to add 5 more types? This is another question. When we can give the answer like this: short-lived phenomenon of early modest protection with death wanes over time, and population-based data demonstrate weak and inconsistent impact of cross protection. Because of that, nonavalent vaccine is in the world, and nonavalent vaccine very high clinical efficacy. All efficacy and immunogenicity trials are resulted. Equivalent efficacy with quadrivalent vaccine for HPV 6, 11, 16, and 18. 97% efficacy for the additional 5 HPV types. Some same immunogenicity for adolescent and adult as the other vaccines. And we have additional information for the future. Co-administration with the other childhood vaccines, and how about previously vaccinated population? If we look this question, how about previously vaccinated population, you can see this table, and you can use nonavalent vaccine for the all cohort, single dose, 2 doses, or 3 doses cases, 2 doses nonavalent vaccine, additional nonavalent vaccine you can use. And how about the HPV vaccination after high-grade SAL treatment? This is a very nice study and randomized control study. Monitored the CAN 2 or 3 after LEAP. Half of the cases vaccinated and the other half is no vaccination. When we look at the recurrent disease with related HPV serotypes, vaccinated group 2.5%, non-vaccinated group 8.5%. It means vaccine works for the recurrent infection. And change in sexual behavior after vaccination. This study showed us no change in sexual behavior after HPV vaccination has shown, published in Pediatrics, as you know. And this is the targeted group for HPV vaccination for WHO and other high-quality gynecological oncology societies. Vaccine introduction to 11 to 12 years of girls and boys. Don't forget, girls and boys, not only the girls. Catch-up vaccination for the 13 to 26 years girls and women, and till 21st years boys and men, expected special groups. You can remember only 25 or 26 years for the years, and preferred timing is before sexual intercourse, but it is not important. As I said, no age limit for women for all 3 vaccines according to EMA. And how about 2 doses? Can we use 2 doses HPV vaccination? As you see here, EMA recommendations and WHO recommendations. You can remember only this one. Less than 15 years old girls and boys, you can use 2 doses easily. It is not necessary for 3 doses. And after the 5th year, positive immune memory had shown. Because of that, no need for booster dose, according to our knowledge just now. The most important part of the vaccination is the adverse events, as they are discussing about a lot of adverse events of the HPV vaccines. And when we look at the adverse events, no relationship with vaccine virus-related infection or cancer due to having no live or inactivated virus in vaccine composition. And vaccine does not contain DNA inside of the virus-like protein. Local reactions, as you know, erythema, little pain, swelling, and fever, and nausea, dizziness, and blockout can seen after the HPV vaccination. This is from the press. New research on HPV vaccine. 2 researchers from the British Columbia University in Canada have criticized the government's stance on the cervical cancer vaccination being safe. Let's look at the study. This is the study, Human Papillomavirus Vaccine Policy, and you can see the researchers over there, 2 researchers, and these 2 researchers are not medical doctors. But can you imagine optical researcher HPV vaccination trial? What's the combination? Why did they publish such a paper? The Voskin Family Foundation donated $950,000 United States dollars to authors. You see here. If you can give me like that amount of United States dollars, I can present another presentation about gastroenterology or any other field. And at the first session, My colleague discussed the primary ovarian insufficiency. There's as you see here, 170,000 million doses of HPV vaccine in 9 years. I searched all the PubMed and data. There are only 6 cases in 3 separated publications. The relations between HPV vaccination and symptoms of primary ovarian insufficiency is important for autoimmune syndrome induced by adjuvants, and there are up to 15 years in cases. And as you know, at the previous session, my colleague presented that between the normal population, the incidence is almost 1%. And you look, only 6 cases in 170 million doses. 83% of the 6 million vaccinated girls in Australia were in school age, and HPV-associated primary ovarian insufficiency was not shown. This is the real data. And this is the meta-analysis about safety of prophylactic vaccines. As you see here, local adverse effects, it is normal, favors control group. It means local adverse effects can seen in vaccinated cohort. And when we look at the serious adverse events, there's no difference between the control and vaccinated cohorts. And how about deaths? There are a lot of questions about deaths. As you see here, with over 270 million doses, 51 deaths in clinical studies. It means vaccine can be the cause of the death. Is it true? No. As you see here, there are 3 organizations monitoring the vaccinated women or girls. None of them are related to vaccines. When we look at the details and when we look from the backward, for murder, traffic accident, over-limit uptake of drug abusers, blah, blah, blah. And you can find these details at CDC's website. And need for screening after vaccination, absolutely yes. Vaccine not effective of all serotypes, even non-Avalan vaccine has 10% gap. And vaccine immunogenicity can be reduced due to inferior compliance to vaccination schedules. And there can be infection due to non-vaccine serotypes before vaccination started. And this is a very nice study from Bosch and presented at 2016, HPV faster screening suggestions. It is very important. If you can vaccinate a woman, only after the vaccination, only 1 HPV testing. If it is negative, don't screen the woman. Vaccination and only 1 HPV testing. As a summary, preteens need HPV vaccine today to be protected from HPV cancers tomorrow. And The Guardian announced that Australia could be the first country to eradicate cervical cancer, as you see here. Why The Guardian announced this announcement? As you see here, free HPV vaccine program in schools had led to a dramatic decline in future cervical cancer rates. Within 40 years, the number of new cases projected to drop to just a few. There's a problem on the screen. As a result, the HPV rate among women aged 18 to 24 dropped from 22.7% to 1.1% between 2005 to 2015. This is the WHO global strategy towards the elimination of cervical cancer. You couldn't see because of the problem of the screen, but I can show you. This is the current vaccination screening coverage line, gray line, and intensive vaccination line, blue line, and intensive vaccination and screening together, pink line. At the end of 21st to 20 year, the elimination of HPV-related cervical cancer can be seen, and this is the project of the WHO. But as you see here, vaccination is mandatory. And the message to take home, for any country, if HPV vaccines will be purchased with educated prices, it is not acceptable with an ethical and political view to exclude HPV vaccination to national implementation program. Shukran.
Thank you very much, of course, for that very good presentation. Now the floor is open for discussion. Okay, Dr. Farah.
Thank you, sir, for your presentation. My question is, we are encounter here a lot of overseas patients who travels from Bahrain to other country and the opposite. So we get this scenario. They have been vaccinated with Gardasil once, and then when they want to take the second dose, they took the Gardasil 9 in another country. So how to proceed with them?
This is a very good question. If you, a woman or boy vaccinated with bivalent or quadrivalent vaccine, you can continue, as I said, with nonavalent vaccine 2 doses. If you vaccinate just now, 6 months later, the second dose.
Either Gardasil or Gardasil 9?
Gardasil 9.
So Gardasil 9?
Yes.
Okay, if it's not available, you can go back to Gardasil?
Of course. Okay. There's no problem about that, but there's no real data about, to answer your question.
Yeah. And the problem here also, the availability of Gardasil and Cervarix, because as doctors, we depend on the supplier. So nowadays, for example, the available one is Cervarix in certain hospitals. So do you recommend Cervarix for teenagers, or better to give them Gardasil?
Better to use Gardasil or nonavalent Gardasil 9, because of the protection from the unagenital wars. For example, England switched the Cervarix program to Gardasil after 3 years of vaccination program. And again, from the Asia, 2 countries switched their national international program from Cervarix to Gardasil, because of the unagenital wars is a very important social problem.
And another issue, as a care provider, we advise women with young girls and boys to take the vaccine. And they go read in the net, and there is thousands of somebody who wrote, I got the vaccine, I got poliomyelitis, I get encephalopathy, I get myocarditis, and they will never listen to the medical analysis because it's already there in the net. Death happened, I got paralyzed. All these people are writing on the net what's their experience. And you know, for common people, they will see what that's written, how to stop this bad effect on our effort to vaccinate our teens.
This is a very important problem for United States too. We can't do anything about this anti-vaccination programs or foundations like the Wolskin family. We can't do anything. We have to show the real data. We showed the real data, and you can say your patients, you can follow from the CDC's website, vaccine, is the vaccine safe? How CDC can say vaccine safe? They can find easily the answers of these questions at the CDC's website.
And I think the pediatricians need now to take a part of it.
Of course,
they are seeing the younger age group still need to be implemented. But I feel very sorry when I get a patient from pediatrician and she or he advise them not to take the vaccine. This is really a disaster happening.
Of course, this is the real problem. The main problem, they don't know the disease. Pediatricians don't see and don't know the disease.
The end result, what we are seeing as gynecologists.
We know the disease. We discussed the pediatricians, how, for example, rubella. dying from rubella per day, only 24 in Turkey. Dying from cervical cancer, 16, 25 per year in Turkey.
Yeah.
Okay,
Yes.
They don't see.
Can we leave a chance for other people to ask, please? Okay.
Might I just a very remarkable question? Well, thank you very much for your excellent lecture. I think this is very important what you stated, is the knowledge, the free available knowledge on the internet does not only affect vaccination. And unfortunately, it's about the general education in the whole world that on the wall, which is not just internet, on the wall, you can, on any wall here, you can write what you want. The question, and you have to educate, and we have to educate our kids at school, that on the wall there can be written whatever, but we as professionals, we have to stick to evidence-based knowledge. And people should be taught what it means that somebody writes something somewhere doesn't mean anything. And unless we are able to teach our kids and our citizens, it will be very difficult to fight with this gossip, because the gossip is so fast that perhaps as fast as light, and we cannot fight against it just with education, because everybody can say whatever, but he needs to have evidence for that. That's it.
I think we're running out of time. Thank you. I think we will end this question now. Thank you very much for Professor.
Is there any chance for one question?
No, sorry. So now we have to move to the next speaker. You know Dr. Abdulaziz Al-Ubaid. He is going to talk today about the role of minimal invasive surgery in gynecological oncology. Please welcome Dr. Abdulaziz.
Thank you. So this time I'm going to be talking about the role of minimally invasive surgery in gynecologic oncology. Again, I have no conflict of interest. In the past couple of decades, there was a lot of advancement in the field of endoscopy. And the adoption is a bit slow in gynecology in general, but also in gynecology oncology. We know that now that minimally invasive surgery is the way to go for patients with benign conditions, and also we can add to them the patients with gynecologic malignancies. If you just think of endoscopy, gynecologists were the first people to introduce it. And I think general surgeons and urologists have way past this in terms of their use and applications. It's not acceptable to do a cholecystectomy through a laparotomy, but it's still acceptable to do ovarian cysts, ectopics through laparotomy. I think that has to change. In oncology, the first use of laparoscopy in oncology was in the 70s. So imagine, about 50 years ago. It was used at the beginning to assess patients with ovarian cancer. 1990, that's about 30 years ago, the use of lymphadenectomy was published by Denny Kirlo. And then other reports followed showing para-aortic lymph node sampling, and Nizhat reported the radical hysterectomy as well in 1992 along with her. This is what you don't want to see, full of scars, especially for women, female patients. Now, it's not only the cosmetic benefit, but the pain, the complications, the blood loss, the duration of hospital stay, the return to work, a huge benefit of laparoscopy. If we talk about endometrial cancer, 80% of women present at stage 1. And these are the patients that are best treated with the laparoscopy. So the standard of care is to do laparoscopic hysterectomy, bilateral salpingo-oophorectomy, possible lymph node sampling, depending on the case. And the NCCN guidelines now, they accept that minimally invasive surgery is the preferred approach for patients with endometrial cancer. Even for patients with high-grade lesions, you can still do laparoscopy, and there is also similar survival outcomes compared to the open approach. The landmark study about laparoscopy in endometrial cancer was published about 10 years ago, the LAP2 study, where patients were having either an endoscopic or laparotomy as a mean of hysterectomy. Endoscopy can be either laparoscopic or robotic, so it's basically the same. There was no difference in regards to the patient characteristics, the disease-free survival, and the overall survival, which is the ultimate goal for your patients, was equal. And the patients, there was no difference in the disease-free survival and long-term survival, but however, the patients tend to do better in terms of complications, morbidity, blood loss. Cochrane published their review, and again, that it's confirming the similar outcome. Again, looking at the secondary outcomes, if we establish that the overall survival and the disease-free survival is the same, the blood loss, the hospital stay is shorter, and fewer complications. But not only the benefits to the patient are limited to the morbidity, the cost to the hospital and to the society is less. So the hospital cost, and when you do a laparoscopic hysterectomy, patient stays 1 day, and in some places they do it as a day surgery. It's much cheaper than keeping the patient for 4 or 5 days. And the patient will go back to work in 2 to 3 weeks rather than 4 to 6 weeks. Obesity, most of the patients with endometrial cancer are obese. And to me, this is the real indication to do laparoscopy. It's for these patients. That's where you have the benefit. 89% of patients with morbid obesity had successful laparoscopic hysterectomy. And yes, it's more difficult, it's more challenging. The anesthetist might give you a hard time and, to put the patient in Trendelenburg. But the outcome to the patient, the complications, the morbidity, the wound infection, even thromboembolism, because if you do a laparotomy, she will stay on bed for 2 to 3 days, but in laparoscopy, she will get up and go home in the next day. So these patients are especially are the best candidates, in my opinion, to do laparoscopy. When we talk about ovarian cancer, in 1990, again, the first report of laparoscopic surgery for stage 1 ovarian cancer was published. Kerlou and Leblanc performed the laparoscopic surgery on 9 patients, and they did the proper staging with lymphadenectomy, pelvic and para-aortic, and they established the feasibility of performing the procedure in these patients. The standard of care for most of the patients, and they usually present in advanced stages, to do laparotomy. And in these patients, in these subset of patients, the role of laparoscopy is limited to assess the possibility of being able to do proper cytoreduction. Despite all of this, no prospective randomized controlled trials in ovarian cancer to show the benefit. However, one of the big series in ovarian cancer stage 1 was published by Brockbank a couple of years ago, I think, in 2013, where they have 35 patients with stage 1 ovarian cancer operated using laparoscopy. The complications rate were low, 14%, and the conversion was 6%. To me, conversion is not a failure. Conversion means that you really think it's better for the patient to do a laparotomy. And that's when you think it's better to do it, then you should do it. So it's not a failure of the surgeon or the procedure, it's rather doing what's best for the patient. The overall survival for these patients was 100%. And the disease-free survival was 94%. So they conclude that the procedure was safe, oncologically acceptable, and it is the preferred method for these patients. So other benefits of laparoscopy is the patient being able to return to her normal life, having bowel movements, fewer postoperative complications. You know, she's not going to be dependent on narcotics for a few days. The other major advantage in ovarian cancer patients is that sometimes we have to give them chemotherapy, and you don't want to delay the chemotherapy for 2 months if the patient has a laparotomy and ended up with complications. In laparoscopy, if she needs to be on chemo, she can be on it as early as 1 week postoperatively. However, there are disadvantages. The staging may not be done appropriately as compared to laparotomy. And the number of lymph nodes evaluated in some studies were less compared to laparotomy. And the other risk is the risk of intraoperative rupture of the malignant mass. So you upstage your patient from stage 1A to 1C. And in studies that looked into the risk of rupture, it tends to be up to 20% in laparoscopy versus 10% in laparotomy. So you have more ruptures. However, it's the selection of the patients. If you think it's cancer and you cannot take it out intact, then the best thing is to do a laparotomy. One concern is the port site metastasis. You will see papers every now and then in the literature documenting metastasis to the port site and discouraging use of laparoscopy in cancer patients. This is true, but the chances are very low, extremely low, 0 to 2%. Now that is the chance of happening. The impact on survival is probably very, very low. So even though there is sometimes port metastasis, it will not impact the patient outcome. And you have more chances of port site metastasis if you do the surgery on a patient with malignant ascites. So usually these are not the best candidates. Most people agree that the benefits of laparoscopy outweighs that small risk. Moving on to cervical cancer, although it's less common, about half of the patients present in early stage and can benefit from minimally invasive approach. Not in this region. In this region, we do see more patients in the advanced stage, and we don't see early stages that often. These are the international guidelines, and I present them out of interest. If you look at the Scottish in 2008, the UK guidelines in 2010, and the German guidelines, I'm not sure when was that, but a few years ago, they all say that for radical hysterectomy, laparoscopy is an acceptable or enough evidence to suggest the safety of laparoscopic radical hysterectomy. And then we had this big hit, slap on the cheek. The last LACC trial that was published in the New England Journal of Medicine, although I'm not speaking to oncologists, but I think there's a huge lesson to learn for everyone, not to jump into conclusion without good evidence. This was published in the New England Journal of Medicine last year by Pedro Ramirez and his colleagues, and they showed, they randomly assigned patients who have open radical hysterectomy versus laparoscopy. And they had 631 women. The median follow-up was 2.5 years. The 3-year survival, if you look at the bottom, the disease-free survival was significantly lower in the laparoscopy group, 91 versus 97%. And that we can debate whether this is the ultimate goal or not, but what's really important is the survival. The survival rate was 93.8% for the laparoscopy group versus 99% for the open group. Now, everybody took a step back and re-looked into his practice. Luckily, I don't do radical laparoscopic hysterectomies, not because I was ahead of my time, but because we don't have enough cases. I don't have enough cases to maintain my skills, and I do them usually through a laparotomy. But that's not the case. With endometrial cancer, almost all of them, I attempt laparoscopy. The pattern of recurrence, interestingly, in the laparoscopy group, both of them had the most of the recurrences in the vaginal cuff, but in the laparoscopy group, there was more dissemination into the peritoneal cavities, probably because of the pneumoperitoneum pushing the cells into the retroperitoneal spaces. So in medicine, you have one landmark study. The next 5 years, the literature will be full of studies to rebuttal against it. And there was concern about the missing data, the ethnic group, the standardization of patients, and also people argue that, if you don't do laparoscopy, you will have 85 additional complications, 70 more blood transfusions to save 4.75 or 5 lives per 1,000. Is this enough? Absolutely enough. If you tell the patient you may have blood transfusion, but the chances of living is increased by a small percentage, I think she will definitely opt for laparotomy. Radical hysterectomy now, I think everybody agrees that laparotomy is the way to go. Robotic-assisted hysterectomy, basically robotic is an endoscopy, but you have the pleasure of sitting, using the instrument from a distance. So, you're more comfortable, your shoulders are not tired, and there are a lot of advantages where you're less reliable on your assistant. The camera is steady, you have a nice 3D vision, and you have the ergonomics to use the wrist movement. The major disadvantage, in my opinion, is the training. If I do a lot of robotic, then I do them. The resident won't get to do a lot with me. So, I try to do at maybe 30 or 20% robotically, but most of the cases are laparoscopic, just to make sure that the resident get enough chance to operate. And basically, the outcome is similar like laparoscopy. It's just more expensive to the institute. That's the major disadvantage. Sentinel lymph node mapping. The sentinel lymph node is the first draining lymph node of the tumor. So if you, instead of doing complete full lymphadenectomy, you try to identify where is that lymph node, that if there is metastasis, it will go there first. And it's like the sentinel soldier who leads the army. How to identify it? We use either technetium-99, blue dye, or isoflurane testing, and try to identify it, take it out, study it. If it is negative, it should represent the rest of the lymph nodes. Why do we do it? Because 80% of the patients will have negative lymph nodes. So doing a lymphadenectomy, not only it will take longer time in surgery, but you have complications. You may have vessel injury, you may have bleeding, you may have lymphedema, lymphocele, name it. So if you can replace doing a full lymphadenectomy with this identification of that sentinel lymph node, this is in a vulvar cancer patient, and it's the blue dye and the immunofluorescence laparoscopically. If you can do it, then it's much better than doing a systematic full lymphadenectomy. But you need the expertise not only to the surgeon, but also to the histopathologist, who should be aware of how to process these lymph nodes and how to do the ultra staging. The NCCN guidelines now accept that it is an acceptable alternative standard of care in smaller tumors. Now I'm going to talk about less single-site laparoendoscopic single-site surgery because I think it's coming, and probably there will be more and more adaptation of this procedure. again, in the 60s, we started laparoscopy, not we in Saudi Arabia, but gynecologists. And Wheelis, who wrote that excellent Atlas of Surgery, Wheelis Atlas of Surgery, in 1969 published the results of large series of laparoscopic tubal ligation with single trocar. 3,600 patients, 2,600 were done with single site. 1969, that's even before I was born. And where are we now? We're still dragging our feet. If you compare our industry, the medicine, gynecology, to others, like the cell phones, we're very, very slow in adopting, accepting, moving forward. And the reason is we are dealing with patients, so we have to be careful when we take it to the next level. In 1991, 29 years ago, the first reported single-incision laparoscopic hysterectomy was published. Despite these efforts, there was still a hesitance and resistance to adopt it because people were worried that they don't have the proper instruments. This is how it was done. A glove that you use the fingers as your extra port and put a rubber band around it to allow prevent the air from leaking, and then you do the surgery through one hole. Very interesting, inspiring technique, but definitely not what's being used now. So we have now better instrumentation, and that's why we have more use. In 2008, the procedure came back, and since then, several publications have been published about the procedure. This is our initial case series. We now have many more patients where we presented this at the ESGO meeting. This is done for patients with adnexal masses. So we do hysterectomies, but this is only limited to patients with adnexal masses. And because it's an oncology referral centers, usually the patients are referred with big masses. And the smallest patient had a cyst of 5 centimeters, but that's because she was having a hysterectomy as well. But we don't usually do 5 centimeters. We do up to 30 centimeters cyst. And the BMI is ranging between 27.5 to even up to 40. We drain the cyst. What we do is we make a small incision for the single-site laparoscopy, start the procedure, inspect the upper abdomen, make sure it's not malignant. So how do we make sure it's not malignant? By A, clinical assessment. Cyst is mobile, patient does not have other symptoms suggesting malignancy. B, radiologic findings, making sure that by ultrasound that most probably it's benign. And C, the tumor markers. Once we establish that, we do the procedure. At the beginning, we used to do salpingoophorectomy for these huge cysts, but now we do cystectomies for the most part. So we have one patient only with granulosa cell tumor, and I will show you the video at the end on how we dealt with it, so not to rupture it inside. This is a patient lying flat on the operating table. She's having a big cyst. She's young. She's in her 20s. She didn't want a laparotomy scar. And this is the cyst by ultrasound. So, and she has hydronephrosis on one side because of pressure. By looking at the ultrasound, you know that this is most probably benign. This is just like a big bag of water, and this is immediately on the operative table at the end of the surgery, where she has a single-site surgery. This is a patient with hysterectomy for endometrial cancer. 4 weeks after the procedure, that's me trying to show the scar. So basically, this is the only scar that she ended up with, instead of having a laparotomy scar. Or it's even better than the conventional laparoscopy because you have less scars and less pains and less blood loss. This is the patient with granulosa cell tumor. We knew it's most probably malignant, but we did it knowing that we respected the oncologic principles. That is, not to rupture the cyst and proceed as if it's a laparotomy. And I'll try to show the video at the end. As physicians, when new technology in medicine comes up, I think we are a bit slow in accepting it, and the reason is that we go through the stages of grief, denying the benefit, dealing with it in anger, trying to negotiate, finally coming to the acceptance phase. The vessel sealing devices, when they came up, I refused to use them. I always insist on using the bipolar because it is safe, reliable, and I'm not wasting money. And I started being in anger and criticizing the others. With time, I realized, I will use it for selected cases, and now I use it all the time. It makes sense. It's very safe, much faster, and the prices are reasonable now. Can you please show the video? I think that's the last slide of my presentation, and maybe during the video showing, we can open the session for questions. So basically, this is a patient with a granulosa cell tumor. It's a tumor on the right side. It measures 7 by 8 centimeters. And this is single-site laparoscopy. So once we did the salpingo-oophorectomy, you have to we sent it you place it in the bag, and then you drain it outside the abdomen. So there is no spillage, there is no drainage. Otherwise, if you take it out intact, you cannot take it out through the incision. But the drainage is done inside the bag, outside the abdomen. So there is no tumor spillage. And we sent it for frozen section, came as a granulosa cell tumor. We went back to continue doing the staging, but not lymph node dissection, because you don't have to do it in germ cell tumors. And it was stage 1A tumor. She was cured, and that case was done at least 5 years ago, and the patient is still fine. And as you can see, the instruments, you can control the angle, articulating instruments, and the vessel sealing devices are just perfect. The surgery is done much faster, and this is shown in real time, so there is no editing. And literally, it takes 15 minutes to complete the procedure. Can you fast forward a little bit, please? So this is the most important step. If I cannot fit it in the bag, I would have done a laparotomy, probably through a fan steel, because you don't need a midline. So the challenge is to place it in the bag and make sure it does not rupture. And to me, this is the most difficult part of the surgery, not because it's technically difficult, but because this is what really is important. And you can see that we did put it in the bag intact and took it out through the incision. So I think I'm running out of time.
Thank you very much, Dr. Abdulaziz, for that nice presentation. I think we have time for 2 questions. Okay, Professor Sanam.
Thank you, Dr. Abdulaziz. That's a very nice talk about using laparoscopy. Actually, we have done less surgery, single port. The problem is most of the patients having insurance, and the insurance were hindering us from proceeding with these type of surgeries. But we have done a big series of ectopic pregnancy using this, as well as hysterectomy using single port laparoscopy. And it works beautiful. It's fantastic. And the other thing is that one report about leiomyomas being malignant made everybody scared, and everybody went back and do the laparoscopy, do the laparotomy, and even the patients start refusing doing laparoscopic myomectomy for them. And that's why you will see a trend of some of us going back and doing open surgery for such cases. So it's a combination of factors for this thing.
Thank you very much. I agree. In the United States, it's cheaper to do single-site surgery compared to the conventional because you use less support and they calculate it with US dollars. It saves about $250 US to do single-site. But here you will have a problem with the insurance companies. What I do is I tell the patients, listen, I'm going to try my best to negotiate a price, and if you are interested, you have to pay if she's covered by insurance. And with the myomectomy, it was done on a sarcoma patient, and the problem is that they use the morcellator, so the cancer spread everywhere. And unfortunately, the patient passed away about a year ago. The alternatives now is that you do the morcellation inside the bag. So there are specially designed bags that you can use, and you do the morcellation inside it, and there is no dissemination. I don't see patients with small fibroids usually, so I don't do myomectomies laparoscopically. Usually the cases I do are big fibroids that are referred specially to the oncologist, and you know, to me, if you do a big fibroid, you need to really suture the myometrium well, because the risk of rupture is higher with laparoscopy compared to laparotomy, because the suturing is not as well as the laparotomy. But now there are bags where you can do the morcellation in. So it applies only to the morcellation, the dissemination part.
Assalamu alaikum. Thank you, Dr. Abdulaziz, for this nice presentation, and I am so happy that you kept the advantage and the disadvantage of the laparoscopic surgery. Actually, at the end, most of the patients, they want to do laparoscopy, and they force us to do the laparoscopy. If we didn't explain to them the disadvantage of the laparoscopy, they will force us to do the laparoscopy. So most of our oncology patients, they are not suitable to do the laparoscopy. And we are trying our best to do a maximum debulking of the tumor. At the end, it is our decision to decide whether to do it laparoscopically or laparotomy. And most of our patients, we need to have an optimal debulking or the maximum debulking that we need. So it is depending on the patient selection at the end. So thank you, Doctor.
I agree. With ovarian cancer advanced stage, you definitely have to do laparotomy. If you do debulking, you cannot do it laparoscopically. Although more than 10 years ago, Chris Pommel published, I think, 5 cases of exenteration done laparoscopically. I'm way below that level, but it can be technically done. I don't do it for advanced ovarian, and I don't think anybody would recommend this to the patient. But the patients would listen to your counseling. We have to tell them the advantage and disadvantage. Personally, endometrial cancer, 80% of the cases I do are laparoscopic. At the beginning, you have to make the choice. If you examine the patient and said, well, the cervix is too high, nobody can argue with you, you will do a laparotomy. If you say there is no descent, if you say the uterus is big, I can find an excuse not to do them, but I would really encourage myself and everyone to push it. We can do hysterectomies open, so it doesn't mean, the anatomy, the principles. I think we should adopt more and more laparoscopy. It's for the patient benefit. But I agree with you. Ultimately, it's your decision. Ultimately, you do what's best for the patient. And if you think the best thing is to do laparotomy, it's not about me. It's about doing the best thing for the patient.
Thank you very much, Dr. Abdulaziz.
Now, it's a great pleasure for me to introduce my dear colleague, Dr. Fatna Al-Khan. She graduated from Arabian Gulf University, Bahrain. She obtained her fellowship in Gynecological Oncology in Istanbul, Acıbadem University, Turkey, under the supervision of mine. Currently, she is a consultant in Gynecological Oncology at Salmania Medical Complex. Today, she is going to discuss about management of abnormal cervical smear.
Good morning, everybody. Actually, it is my great pleasure to be presenting in presence of my mentor. My presentation will be about the management of abnormal cervical smear. I'm very happy to see this number of audience. It's really make us happy, these numbers, that the conference is really successful. And I'm sure the audience, they paid attention for each presentation given first, because I was planning to ask this question, but the answer was given in the previous lectures. The first question of my lecture would be, do you think that one day cervical cancer will be eradicated or not? He got his information from the Guardian newspaper. I got my information from the BBC. The BBC, they announced that Australia public health, within 20 years, the cervical cancer will be eliminated from Australia. And in 2022, it will be labeled as a rare cancer, because they are estimating that the cancer prevalence will be 6 in 100,000 of population. This is why, because Australia, they are one of these countries, they started the screening programs from the beginning 90s, in 1991. Then in 2007, they started the immunization program, national immunization program. So if they maintain that these two national programs, within 20 years, Australia, they will eliminate the cervical cancer. Introduction, cervical cancer is considered the 4th most common cancer in the women worldwide. In Bahrain, interestingly, I found 2 results. First, which is published by WHO, it considers as a 3rd most common cancer. Then the International Agency of Research on Cancer, in 2018, it's published it as the 8th most cancer. So it is a great difference between the 2 results, maybe because of registration of the other cancers became better. Unfortunately, the screening system in Bahrain still is opportunistic, and it covers only 43% of the targeted population. For any screening system to say it is a successful screening system, it should cover more than 70% of participants in a targeted population. And we are doing collecting the smears by cytology method. HPV vaccination is not introduced in the national immunization programs. And the HPV vaccine also, it's not available in the public hospitals or facilities. It's only available in the private hospitals. The most common prevalence of HPV is types 52, 16, 31, and 51. The WHO, they have 3 recommended programs for screening: the breast cancer, cervical cancer, and colorectal cancer. They do not recommend screening to be below the age of 25 or above the age 65, and never to do annual screening. The American College of Obstetrician and Gynecology, they have their guidelines of screening. They do not recommend to do screening below the age of 21. Why is that below 81? Because the incidence of cervical cancer below this age is very low, and there are no evidence or researches that prove the effectiveness of doing screening below this age. And by doing the screening below this age, also you will create more anxiety and unnecessary follow-up and interventions between this group. From 21 till age 21 till 29, only cytology, and cytology should be done every 3 years, the screening. From 30 to 65, we have 2 methods for screening. The co-testing, it is the HPV and cytology, and if it is done, it will be every 5 years. The second one is the cytology alone, and it will be only for every 3 years. The preferred one is the co-testing. If the patient is above more than 65 years, the woman, it is not necessary for screening, but she should have adequate negative smear results, at least 3 for cytology and 2 for co-testing. If the patient, she has a history of CIN, 2 or 3 adenocarcinoma on cyto, and should be continue, or cancer, they should continue routine screening for more than at least minimum 20 years. Patients who had hysterectomy, also they had to have, they should not have screening, but if they have a history of also, again, CIN2 or adenocarcinoma, they should also be followed at least for 20 years. The answer for vaccinated patients, yes, they should follow the screening because the vaccination will not cover all the oncogenic HPV. The cofactors for lesions and the pre-invasive lesions, the most cause is the HPV infection, smoking, immunosuppression, and other genital infection, hormonal, steroids, multiple parity genetic disorders. HPV subtypes, there are more than 200 of HPV subtype, 50 and 100 there are like oncogenic HPV. 15 of them, out of them, 15 of them is considered as a high-risk HPV that will cause cervical cancer, and the low risk, the most. So this study shows that most cervical cancer is caused by HPV. Almost reaching to 100%, it was for cervical cancer compared to the control. And the most common, the HPV they found, it is 16 and 18. These terminologies or abbreviations that we use in when the pathologists, they interpret their results for the cytology and the biopsy of the cervical smears and biopsies. And the cervix, it has two types of cells, ectocervical, which is the squamous cell, and endocervical, which is the columnar. So these are the systems that were available for interpreting, the pathologists interpret the cytology and the biopsy. We have several systems. In Bahrain, we are following the Bethesda system. If we compared between the sensitivity and specificity of cytology and HPV test, we can see here, notice that cytology, it has less sensitivity compared to the HPV test, but the specificity almost they are similar. The management of the abnormal smear guideline, we'll talk with a few slides that are coming, is according to American Society Cervical Cytology and Pathology. There have been changes from previous guidelines. The cytology, if negative, but no endocervical cells, there's no need for early cytology repetition. If the endocervical curettage, it was CIN1, that means should be considered as CIN1 for the management. Repeating the screen is required if cytology result is considered insufficient, even if the HPV is negative. Colposcopy is recommended even if cytology is negative for HPV 16 or negative for HPV 16 or 18 positivity. Direct colposcopy is not an option for ASCAS, because before ASCAS, we had in the triage of ASCAS 3 options. And one of the options were the direct colposcopy, and nowadays there is no direct colposcopy for ASCAS. If ASCAS HPV is negative, it should be monitored with co-testing every 3 years instead of 5 years. Management of women age of 21 and 24 should be evaluated separately. We come with a few slides. It is very important slides, but actually I need, because the pointer is not working, so we will concentrate on the main points in these slides. If the results come from the lab, we're showing that the Pap smear results unsatisfactory, because most of these results will be faced in health centers or general gynecologists. So what is the next step? If HPV unknown or HPV negative above the age of 30, we repeat cytology at 2 and 4 months. No need to repeat at the same set. And if HPV is positive, more than age 30, colposcopy can be done, but both of all repeat. Both of them acceptable, but here we can see the repetition. We concentrate here that we can repeat within 2 to 4 months, because we have several conditions. You can repeat the cytology less than 1 year. This is one of the examples. If the report came with negative for intraepithelial lesions or no malignancy, but it is written that transformation zone or endocervical is absent or insufficient. What can we do this time? So if it is between the age 21 or to 29, the patient should go routine screening. No need to repeat the cytology. If the age is more than 30 and the HPV is negative or HPV is unknown, so we can repeat the cytology at 3 years, which is acceptable, but the recommended is to do for HPV negative to do the HPV testing. If it is positive, then a smear test again at 1 year or genotyping to know which type of HPV. Is it the high-grade HPV that's 16 and 18? If the patient came more than 30 years old and cytology is negative, but she has HPV positive result, here we have two options. We have to repeat the co-testing at 1 year. This is the acceptable. HPV DNA typing at 1 year, it's also the acceptable. And if it is negative and HPV is negative and cytology is negative after that, we repeat the co-testing at 3 years. But if the DNA typing came for the patient that HPV is 16 or 18, so the patient she will have to do the colposcopy. The second thing, when the patient she came with the cytology, ask us. So here we have only two options: repeat co-testing at 1 year or HPV testing. So the HPV testing, it is the recommended, but we can do the repetition, the co-testing in other facilities. And unfortunately, in our facility, we cannot do the co-testing. So what is the advantage here? We see so many times we repeat cytology or do HPV. What is the advantage of cytology over the HPV testing or vice versa? The advantage of repeating cytology, it is easy and it is available everywhere. The disadvantage that 30% of the high-grade CIN cases can be missed, and 30% of cases may disappear. The patients, they will not come for follow-up and they will disappear. The HPV test, it has a negative predictive value more than 99%, and the sensitivity in detecting high-grade CIN is more than 95%, 50% reduction in referral colposcopy. And it will increase also the specificity for colposcopy reflex testing when we are using the liquid-based pap smear. For management for the patients between 20 and 24, they have different management. So if the patient came either ASCAS or lower grade, so usually this group of patients will not do for them HPV, but if HPV as a routine. So we repeat the cytology at 1 year, it is the preferred one. If HPV will not do the HPV course, no, reflex. That means the same sample will see what is the type of the HPV. If it is positive, again, we'll repeat the cytology. If cytology after 1 year showed ASCH or atypical glandular or high grade, then the patient, she needs colposcopy. Other than that, we can repeat cytology at 1 year. And if two consecutive negative cytology, then the patient will go for routine screening. ASCH, in ASCH, there is no need to do HPV. It is already considered as a high grade. So the management will be direct colposcopy. The management of ASCH and high grade in the age of 21 to 24 will be different. We'll do also colposcopy for the patient. And this age group will not do for her immediate, it is unacceptable to do for her immediate loop excision. And if she needs the excision, it should be excisional. It should not be ablation, because we can read the specimens much better. The management of lower grade SILL, if HPV test is negative, we repeat the co-testing at 1 year. If the HPV came with the HPV, there is no report of the HPV, or the HPV is positive, then the patient will go for colposcopy. Management of pregnant women with lower grade SILL, colposcopy is the preferred, but we can delay the colposcopy till 6 weeks postnatally, because the colposcopy for the pregnant lady should be done by expert. We prefer to be done by gynecologists, oncologists. The high grade here, immediate loop electrosurgical excision or colposcopy with endocervical curettage. If the patient, she had atypical glandular cells in the report, so for atypical endometrial cells, we'll do for endometrial and endocervical sampling. If there is no pathology for endometrial pathology, then colposcopy. If all subcategories except atypical endometrial cells, colposcopy with endocervical curettage and endometrial sampling if the patient is aged more than 35 years old. The management of atypical glandular cell, we have two abnormalities: atypical glandular cells not otherwise specified, or the atypical glandular cells favoring neoplasia. For favoring neoplasia, we'll go directly for diagnostic excisional procedure. And for for atypical glandular cells not otherwise specified, if there is no CIN or no glandular neoplasia, so we'll manage per ACCP guidelines. But if there is no CIN2 or adenocarcinoma, they will do co-testing at 12 and 24 months. If the both results were negative, then for co-testing for 3 years later, co-test 3 years later, if any abnormality, colposcopy. So I think the question now came in your brain, so many guidelines, so many arrows, so many tables, yani what we can do, yani I cannot memorize all these and follow all these. We have to thank the technology. The technology, they create for us an application. It will make life easier, and it is available in Apple or Androids. It's much, much easier for management of these kind of abnormalities in cervical smear. Why I use the ACCP guidelines? Because the National Comprehensive Cancer Network, they advise to follow these guidelines. And also the American College of Obstetrician and Gynecology, also they advise to follow these ACCP guidelines. Cervical intraepithelial neoplasia, CIN. We have CIN 1, 2, and 3. And pathologically, CIN1 means it's only the third of the thickness, CIN2 the 2/3, and the CIN3 is the full thickness. The cervical cancer risk time, if we say that the patient is not following screening, it is 1 in 100 cases. For lower grade, and with follow-up, it will be 1 in 500. For all CINs, even after treatment, will be 1 in 250, high grade and treated within 20 years, 1 in 3. HPV infection without a treatment, 5 to 10 cases per 100 cases. The CIN1, we can see here, CIN1, 60% of it will regress, and only 1% of it will be invasive cancer. Whereas the CIN3, 33% will regress, more than 12% will progress to invasive cancer. Okay. So here, if we have CIN1, the patient previously came with a report of ASCAS or a lower grade SIL, and then colposcopy done for her, and the results came. So follow up without treatment. No, I mean, we'll not do colposcopy for her. We'll follow up without a treatment. Patient, she needs only co-testing at 1 year. If came higher or or HPV positive, then she will go for colposcopy. If HPV negative and cytology negative, again here written with the star, age appropriate retesting, according to the patient age. 3 years later, repeat again the retesting. Cytology if negative, HPV negative, we go for routine screening. CIN preceded by ASCAT or high-grade cytology, we have 3 options: co-testing at 1 or 2 years, diagnostic excisional procedure, or we ask the pathologist to review, because with a high-grade pap smear, the biopsy came CIN1. Management of women of age of 21 to 24 with no lesions or biopsy-confirmed CIN1. After ASCAS or lower grade, we repeat the cytology after 12 months. If she had the patient ASCH or high grade, so we'll do a colposcopy. If adequate colposcopy, she has 3 options: diagnostic, excision, procedure, colposcopy, cytology, and review again the cytological histology and colposcopy findings. So the treatment for CIN, when we treat CIN1, if persistent more than 2 years, lesion, it progressed in the cytology evaluation, and cytology of ASCAS or lower grade SIL inadequate, it was inadequate colposcopy, or the ECC was more than CIN1. And the cytology for ASCH or high grade, no lesion, we found the colposcopy, no lesions, but the biopsy showed CIN1 and ECC. The management for a pregnant lady with the CIN2-3, if adequate colposcopy, excisional or ablative treatment. But we have to exclude, we have to exclude pregnant and the age of 21 till 24 years. If inadequate colposcopy or recurrent CIN2 or 3 and ECC CIN2-3, then diagnostic excision procedure. For this age group, again, we have CIN2 or 3 observation only with colposcopy and cytology at 6-month interval and for 12 months. Treatment using excision ablation of T-zone, 2 cytology if negative, and normal colposcopy, then co-test at 1 year. If both of tests are negative, then co-testing at 3 years. So if we did the excision and the margins are positive, when to do a reflex hysterectomy if fertility is not desired, possibility of invasive cancer, more stage less than 1A, re-excision within. We can re-excise again within 1 to 3 months, CIN2 ectocervical or endocervical margin, especially if age more than 50 years. The complication rates are the same for the primary intervention, and the effect on fertility and pregnancy is uncertain. Ablation excision is not recommended in case of invasive cancer, and the benefit is questionable, and the effect of re-excision fertility and preterm birth is uncertain. The CIN2 and 3 and hysterectomy, why done hysterectomy for them? Because of other reason than CIN2, cervical conization, it was impossible for them, or LEAP or conization margin were positive for CIN, and fertility is not required. Or the patient, she has a phobia and pushing the physician, please do for me the hysterectomy. So if it is not advised to do hysterectomy for any abnormal smears or pathology, because the study done, 94 hysterectomy done for CIN2 were positive. The patient later on in follow-up, they had vaginal cancer, 2.8%. The management for adenocarcinoma in situ is hysterectomy preferred. If the patient, she wants fertility, then we can follow up, but it should be excisional, and the margin should be, if the margin is negative, then she will have long-term follow-up. The take-home message: screening in adolescent is not recommended. Management for women between the age of 21 and 24 should be evaluated separately. HPV DNA test, it is important place. It has a place in the follow-up and screening, but the patient should be done more than 30 years old, and we should not do it below that age. And there is no place in primary management for ASCAS or low-grade SIL. Direct colposcopy is not an option of ASCAS. Hysterectomy should not be performed with cytological diagnosis. The primary treatment for high-grade SIL is not hysterectomy, because the hysterectomy, because the local treatment and the hysterectomy, both of them, they have the equal chance of recurrence. The colposcopy is a very important cornerstone clause. 1 year and long-term follow-up is essential, and thank you for your attention.
Thank you, Dr. Fatma, for this excellent review and very clear stated take-home messages. We're running short of time, but we'll take 2 questions. Please go ahead.
Thank you, Dr. Fatma, for this elegant presentation. I have 1 question and 1 concern. Regarding the postnatal checkup, we have to do now routinely screening for all the patients with Pap smear, even if she is low risk, or even if she did less than 3 years. And the second concern, please re-emphasize who's supposed to do colposcopy. As in our kingdom, all the general obs-gynae and gynecology, they are doing colposcopy. I don't know if they have an experience or fellowship in colposcopy. Please re-emphasize who's supposed to do the colposcopy. Thank you.
The colposcopy should be done by gynecology oncologist, or who is certified in the colposcopy itself, because it will be difficult for any general to interpret the colposcopy results. And for the postnatal, actually I did not go through any literature to find is it mandatory to do postnatal checkup Pap smears.
Because we are referring the patient after the 6 weeks to do postnatal checkup with Pap smear. Here, all Bahrain. Do we have to do it routinely now or no? I can take an opinion of Dr. Abdulaziz.
I think we do it because it's a good opportunity. The patient is there, so we do it. But it's not a recommendation to be done in the postnatal. But we take it as an opportunity because they don't come for checkup or screening. So if it's done within the past 3 years, I don't see a point of repeating it. That will be my opinion, if you agree.
It is like you are catching up the patient. Yeah, you are doing opportunistic. The most studied in Bahrain for the HPV positive, all done in the postnatal patient. It is not done for a patient going for a checkup for routine or regular gynae checkup. No, she's going for postnatal. She's doing the Pap smear.
Yes, regarding this postnatal opportunity to do the Pap smear, where I had my fellowship in Australia, they were sending a letter every 3 years for the women to remind them about the Pap smear, where maybe we can implement this in Bahrain. One question I have that in adolescent, in culture where they are practicing unprotected sex, at the age of 9 they will come pregnant. Is very common for them. Any studies regarding starting Pap smear in this culture? And another question, please. For patients who have vaginal or hysterectomy in general, do we need to do Pap smear for them later on if we don't know their HPV status? Thank you.
For your question, we can start first as education. We give the child education, then by starting the HPV vaccination. Before when I joined the medical school, it was like that we initiate the screening once the patient is sexually active. Now, no, it is not recommended because the incidence is very low, and even the immune system in this group, it's very good and excellent and can eradicate the infection. So it is not recommended.
Thank you, Dr. Fatma. Thank you again very much. Next is Dr. Maryam Mohammed, who I think is well known in the Bahrain Obstetrics and Gynecology Society. She's a gynae-oncologist at Salmaniya Medical Complex. She is certified as a consultant gynecology oncology based on Arab board certificate, and then she did her fellowship training at King Faisal Hospital. Dr. Maryam.
Thank you, Dr. Abeid. It's actually my pleasure to be here and to be part of this event. And today I'll talk about the endometrial cancers in terms of prevention and screening. I will not talk to the management, but I'm happy if later on if you have any questions regarding this. So I have no disclosure. So I'll talk first about the risk factors and then the classification, the risk factors, and how if we can prevent the endometrial cancer and the screening. So as we know, that uterine cancer is the most common gynecological cancers in the developed country, but it is the second most in the developing countries, the low incomes after the cervical cancer. So the incidence and the peak increases in the between like 50, 55, and 70. So it's actually the risk after the 55. But there are few cases of 2 to 5% occur before the age of 40s. So the risk, when they studied the risk of endometrial cancers with patients postmenopausal with the bleeding, it was ranging between 7 and 12. And of course, we know that the endometrial cancers has an early symptoms, so patients will come to you and with an early symptoms and with early detection. So the evaluation will be usually by the endometrial biopsy and also the Pap smear. So the sensitivity of the endometrial biopsy in this is reaching up to 90% or higher. Regarding the Pap smear, it is reaching the liquid base, maybe reaching up to 50 to 60%, resembling aegis not otherwise specified or aegis fever neoplasia. Our data in Bahrain regarding the incidence of endometrial cancers, where this data was taken from Bahrain Medical Bulletins, was issued in 2016, and as you can see, the endometrial comes after the ovarian from the gynecological cancers, because in our institutions we're seeing endometrial cancers more, but this is maybe the whole data, and the incidence was reported as 5.4 per 100,000. So this study was taken from 1998 to 2011, where they studied all the new cases of the cancers in female and in males. Regarding the classifications at the beginning of, maybe because before in the 70s or the 60s, they were thinking that endometrial cancer is just one disease, but it is heterogeneous. It had a lot of classifications. And then later on in 1983, Bookman studied 600 cases of endometrial cancer and during 20 years, and he classified them into type 1 and type 2. According to the histological and clinical pathological behavior. Then 2014, the WHO have the final, classification of type 1 and type 2. And then we have the new classification, which is depending on the genetic profile of the tumor. So I'll talk about the type 1. The type 1 is mainly coming into the patient who is polycystic and obese, premenopausal maybe, and it's including histologically. You will have most common is included only grade 1 and grade 2 endometrioid, and it's most common, 80% of all endometrial cancer. And as I said, it is a stimulated dependence on estrogen and proceeds by hyperplasia or endometrial intraepithelial neoplasia. And generally, it is a good prognosis, better than type 2, and has an early detection. The type 2 is including the grade 3 endometrioid, serous, clear cell, mixed cell, and differentiated, and the Carcino Sarcoma. Actually, Carcino Sarcoma was included at the beginning with the mesenchymal, but because they studied the origin of the disease, and they saw pathologically it's started from the carcinoma components of the tumor, which is transferred into mesenchymal later on. So originally it is a carcinoma, so it's considered as part of the epithelial tumors. And this type 2 usually has a poor prognosis, detected late, and the clinical behavior of the disease, it's like the ovarian. The patients will come to you with ascites or mental caking and will not come as early as with just a bleeding like type 1. usually as a gynecologist, we usually after the surgery, we wait for the pathology to see what is the result in order to classify our patient to low risk, intermediate risk, high risk. Grade 1 generally is low risk, but we have other risk factors we have to look at to decide whether patient is low risk or high risk or intermediate, according to the stage, grade, histological type of the disease, the lymphatic space invasion, and we can include the age of the patients to determine that it is a high risk or low risk, because this will determine and will lead us to decide whether she needs adjuvant radiation or adjuvant chemo, even if it is, advanced stage. So I'll come to the genomic, classification, molecular classification. Actually, this one is taken from Nature 2013, and where the cancer genomic at ATLS studied the genetic profile of the disease. And they divided into 4 classification. This is, which is the number 1 is POL ultra-mutated, hyper-mutated microsatellite, MSI, and the COBE number low microsatellite stable group, and the COBE number high is serous. This information I complicated for the some, because the pathologist will be more expert in this. So talking about this, every this one subtype has a different histological features, different molecular features, of course, and different clinical features, and in terms of prognosis also different, and the treatment also, because if you know the genetic profile, you will see you will detect more. You know the pathogenesis of the disease, and you decide even for the treatment, recurrence and metastasis, whether there is a targeted immunotherapy later on the patient can receive or not. So summarizing, interestingly, this is you will see this endometrioid grade 1 can be POL, which is a good prognosis, and can be intermediates. And you see endometrioid grade 3 has a poor prognosis, and along with the serous, which is type 2. This is in the terms of tumor grade and the prognosis. So before, talking about preventions, we have to know the risk factors in order to prevent the disease. So when they studied the risk factors, actually for type 1 and type 2 almost the same. Although the type 1 is estrogenic, type 2 is not estrogenic dependent, but most of the risk factors are the same for both. So starting from the increasing age, unopposed estrogen therapy, tamoxifen, and each has a different relative risk, as you can see: obesity, polycystic, nulliparity, diabetes. I'll just go through this separately. So, this estrogen play an important role in the pathogenesis of endometrial cancers. So we have either it is exogenous sources or endogenous sources. So when they studied this, the hormonal effects on the pathogenesis of endometrial cancer, so there was this one meta-analysis of a randomized trial of hormonal therapy in postmenopausal women, which was the increased risk of developing endometrial cancer was significantly high after using only 1 year of high dose of unopposed estrogen. And it has been estimated also that the absolute risk of endometrial cancers is 1 in 1,000, but in the patients taking unopposed estrogen, the risk increased from up to 1 in 100. So I'll talk later on about tamoxifen and the surveillance for it, but I'll just go through it. We know that tamoxifen is the selective estrogen receptor modulator, and it has an agonist effect and an antagonist effect. and actually it's a competitive inhibitor of estrogen. So it's, that we used in these breast cancers as a prophylactic of the recurrence. So, but it has, from the pathophysiology side, it's, the effects, it differs from postmenopausal to premenopausal. Because in the premenopausal, the estrogen level is up to more than 20. So the effects, or the antagonist effects of estrogen on the uterus will predominate, because there is an endogenous estrogen high stimulation of endogenous estrogen. So the effects of antagonist will not be there of tamoxifen. Whereas in postmenopausal, the estrogen level is low, so the agonist effects will be more predominates on the uterus. So that's why the estrogen agonist in postmenopausal it differs in this pathophysiology. So the risk in postmenopausal is more than the premenopausal, and in postmenopausal it's also differs on the duration and the dose also in the risk of endometrial cancer. The risk of endometrial cancer in premenopausal, because of that effects, is not that established. So regarding clomiphene, because I'm talking now about exogenous, the exogenous sources. So the clomiphene also, when I go through the literature, actually there was no data, showing the effects of clomiphene and the risk, or whether it's increasing the risk of endometrial cancers or not. So talking about endogenous sources, in the postmenopausal transition, the estrogen exposure is high, so the risk is in this period is high, and in the, as we know, the polycystic ovarian syndrome, insulin resistance, and of course in the nulliparity and infertility, also of high exposures of endogenous estrogen. So another endogenous source is the obesity, of course. Obesity play an important, it's one of the main cause of the endometrial cancers. There is a strong association between both. And as we know, because this obesity has an high endogenous sources of estrogen, happens in the adipose tissue from transformation of androstenedione to estrone, or aromatization of androgens to estradiol. So when they studied this, there was a meta-analysis of 24 cohort and control studies of around 14,000 endometrial cancer and 35 control. They noticed that the endometrial cancer increase when the BMI increases. So whenever the odds ratio was 1.4 for the BMI of 25 to 30, 2.5 for BMI of 30 to 35, and reaching to BMI of 7, odds ratio of 7 for BMI of even 40. So it's really an important, more than half of the cases what we see, and in our clinic or in our practice is obese patients having endometrial cancer. So when we see the obese, we just say that she's a high risk. So as I said, that increased BMI increased the incidence. And there's another meta-analysis of this study, 26 studies by American Institute of Cancer Research. For every, they noticed that every 5 BMI increase, there will be a 50% increase in the risk of developing endometrial cancers. And there will be also associations of high mortality rate with morbidly obese having endometrial cancer. I think this is because of the association of the comorbidities. Usually obese patients will have diabetes and other comorbidities, hypertension. Other endogenous source of estrogen is the granulosa cell tumor. I mean, I always like, you know, the recommendation actually, if you're going to fertility sparing surgery for those patients, I think better to do the DNC just to make sure that there's no hyperplasia or endometrial cancer there, because when they studied this, they show that they noticed that it is 5 to 10% risk of malignancy there, and hyperplasia I think maybe reaching up to 20%. Early menarche, late menopause. Again, it's the long time of exposure of estrogen. And here we come for the genetic factors. We have the Lynch syndrome and the Cowden syndrome. Cowden syndrome is actually a rare one. Lynch syndrome is have a high risk of developing endometrial cancers, up to 70%, compared to 2.6 in the general population. And the majority, they found it's endometrioid type. The Cowden is mutations, the B10 tumor suppressor gene, and there is it's a rare autosomal dominance. Both of them are autosomal dominance, but Cowden is rare, and it's associated with increased risk of endometrial cancer, thyroid, colorectal, breast, and renal, and has lifetime risk of 13 to 90%. Diabetes, well, these other risk factors, but I mean, before we were just thinking that it is like uncertain risk factors, but nowadays, because of this, I mean, we found that it is really, there is a close or association between both endometrial cancer and diabetes, and there was a meta-analysis of 22 cohorts and case control studies where they found that there was statistically significant association between diabetes and the risk of endometrial cancer. Hypertension, uncertain. Phytoestrogen is still, there is conflicting data, whether it is a risk factors or not. So can we prevent the disease? I think we were talking about the risk factors. I think we would just have a hint how to prevent the disease. Medication-wise, we have the hormonal contraceptions, which can reduce the endometrial risk, endometrial cancer risk up to 30 to 40%. And this was studied, and they studied even the effects was resisted even after discontinuation of the OCP pills. Increasing gravity and parity also. And this is another one where, well, it's older age at last birth. When they studied this, there was 17 studies over 8,000 cases of endometrial cancers. And they found that the women who having a late delivery, I mean, at the age of, the cut point was 35 years. They found that the risk of endometrial cancers also decreased in these patients. The breastfeedings also reduce cancers up to 11%. Smoking, well, it can reduce in premenopausal, but in decreased risk in postmenopausal, but not in premenopausal. As smoking, I think, stimulates only the hepatic metabolism. So I'm thinking the postmenopausal, they have less, and so they can have benefit from this. I mean, the only benefit maybe. And physical activity and diet, actually there was no definite data, evidence-based, like encouraging this, but some studies, they show that the coffee and the green tea, they even increase the dose of that. I mean, taking this will also help in protection against endometrial cancer. Now, strategy of preventions, I will just go through the high risk, which is who are taking the tamoxifen and who is having the genetic disease. So regarding the genetic disease, the medication-wise, we can start them on OCP pills, which has reductions of 50 to 60%. Or progesterone-only contraceptives also may help. And ultimately, patient needs definitely a risk-reducing surgery with hysterectomy and bilateral subangiorectomy. Tamoxifen, levonorgestrel, IUCD, Mirena was proposed, but I think the safety of that is not well established because usually the breast cancer, if you started patient tamoxifen for breast cancer and you wanted to put a Mirena, you don't know the receptors there in the breast whether have progesterone positive. So the safety of this is not guaranteed. The polycystic ovarian syndrome, we can start estrogen, progesterone at the first line for endometrial protection. The prevention regarding obesities, of course, the life modifications is important. Again, the diet, which type of diet, and this was not, well established. The bariatric surgery, there was a meta-analysis observation study, reduction of the risk up to 60% among those who had the surgery compared with the obese who had not. The progestin dominance contraceptive or contraceptive pills also will have also, again, the reductions of 24% of developing endometrial cancers. Metformin, whether it helps in these people or not, it's still under investigation. So for an average risk, for the normal people, you just advised for maintaining normal BMI, physical activity, breastfeeding, and use of hormonal contraceptives. Can we screen for that? Actually, endometrial cancers, there was, with the recommendation or consensus of the organization, they recommend not to screen except maybe for those who are having genetic factors. So I'll just go through the Lynch Syndrome. Again, it's the risk is up to 60%, and it has also an ovarian cancer risk. So that's why when we do the surgery for them, we remove also the ovaries, because the patient has to understand that there is a risk of 20% of ovarian cancer. The screening usually started from 30 to 35 years. And with the biopsy and with the transvaginal ultrasound. Regarding chemopreventions, chemoprevention means the hormonals and the OCB pills may help reducing the risk. Also progesterone reverse the hyperplasia and the risk reducing surgery. So the ACOG recommendation for the Lynch syndrome, those who are having Lynch syndromes, so the colonoscopy annually, the endometrial biopsy, and starting from 30 to 35, and prophylactic, again, hysterectomy, bilateral ambulatory. The Cowden syndrome, there is no established guidelines because it's a rare. Maybe it's like this one, Lynch syndrome. So talking about tamoxifen and the effects, because I brought this because I know this, as a gynecologist, we are facing a lot of patients who are breast cancer, taking tamoxifen, whether to do endometrial biopsies or not. So there is a lot of conflict for that. Actually, the tamoxifen increased the risk of pathology, of course, in the endometrial cancer, the pathology of uterine. And the most common is polyp, and then comes the hyperplasia, carcinoma, sarcoma, and even Carcino Sarcoma. And tamoxifen increased the risk up to 2 to 3-fold. And the rule of endometrial cancers, 5 years of tamoxifen is 0.3. The rate is 0.3 in postmenopausal and 0.1 in premenopausal. The risk was studied with the duration, and whenever they increase the duration, increase the risk. Regarding the dose, whether to give 20 or 40 tamoxifen, will not, I don't think it's changing in the effect and the risk of endometrial cancer. The risk normalize usually after 2 years of session of tamoxifen. The postmenopausal woman, of course, if she's having bleeding, means she's symptomatic. So you go for the usual evaluation with the endometrial biopsy, transvaginal ultrasound, and we know that endometrial biopsy is the first line. And the office one, because it's especially if it is if the disease is occupying more than 50%, so it is more effective. And if you find an ultrasound pathology and you're not sure what is there, so you go for hysteroscopy or sonogram. If suppose any difficulty getting the biopsies or the follow-up is needed for that patient, persisting bleeding, and you don't know what is there, so you go for DNC, of course. The premenopausal, as I know that, as I told you, the risk is less with premenopausal. So even the ECOG, they didn't give any guidelines to do that. I mean, the normal gynecological follow-up might be helpful for the patients. And if you are not sure what's going on, because some patients, they are taking tamoxifen and the age is, you don't know whether she's postmenopause or premenopause because she's having amenorrhea. So at that stage, maybe you can, the FSH will help you to check the menopausal status. And if, so if premenopausal, so no, if the test was low, of course, you will not go for a biopsy unless if she's symptomatic again. Symptomatic means you do biopsy and transvaginal ultrasound. The incidental findings of patients asymptomatic and the thickened endometrium, nothing to do, no need to do anything, because usually the appearance of endometrium with patients on tamoxifen will be like thickened and like cystic, so will be suspicious if you look at it, but actually it is nothing since patient is asymptomatic. And if there is a polyp, you need to resect it, I think, because the risk of malignancy was found up to 5%. So the issue is quite controversial here, but we have the recommendations of the ECOG 2014 that they recommend no screening for asymptomatic patients. So the take-home message is there is no major recommendation for screening, and I think the public awareness is important things that patients has to know that the obesity has a role in that, in the risk of endometrial cancers. And they have to report any bleeding or abnormal spotting. Treat the pre-malignant disease, of course, you have to. And as I said, prevented by healthy lifestyle. And I think the genomic subtypes is the future of endometrial cancer, because I think it will lead us to the new diagnostic test, treatment, even management, and even the maintenance treatment of the recurrence disease or the maintenance in terms of immunotherapy. Thank you very much.
Maybe we have time for one question. No question. So you're encouraging smoking?
Yeah, after this, yeah.
Thank you, Dr. Maria.
Postmenopausal only. Thank you.
Now, our last presentation in this session will be given by Professor Kosa again. He's going to talk about lymph node dissection and gynecological oncology and updates. Please welcome Professor Kosa.
Thank you very much, dear chair, dear colleagues. Don't leave the hall. I have a couple of videos for your attention. This is a very special topic, I know. This is the questions about lymph node metastasis. We have 5 questions. The first one, is the lymph node involvement a poor prognostic factor? What is the accuracy of imaging techniques on lymph node metastasis? How about the complications of lymphadenectomy? Could we plan the adjuvant treatment according to the lymph node involvement? Has the lymph node metastasis any effect on disease-free survival and or overall survival? You know anatomy of the pelvic lymphatic system. Recently published data, there are 3 pathways of the pelvis. For the first one, lower paracervical pathway. The second one, upper paracervical pathway. The last one, infundibulopelvic pathway. According to Cibula, this is the lower paracervical pathway, and this is the upper paracervical trunk. these are the real pictures. Could you please close the spots? These are the real pictures of upper para-aortic lymphadenectomy and lower para-aortic lymphadenectomy below the IMA, and perisacral lymphadenectomy, pelvic lymphadenectomy, and pelvic lymphadenectomy. You see the obturator fossa from medial, from lateral. And we have to conclude all the cancers side by side. First of all, cervical cancer. These are the prognostic factors for cervical cancer. The most important cervical factors: tumor volume, parametrial involvement, as you see here, and positive margins. The lymph node metastasis is the most important part of the tumor volume for cervical carcinoma. This is a very old published data, but shows us the 5-year overall survival rates. If lymph node negative, as you see, 90%, pelvic and para-aortic lymph node metastasis, and according to the metastatic lymph node numbers. Lymphatic staging before treatment is important. Failure in clinical staging 50 to 56%, and upstaging due to micrometastasis. Para-aortic lymph node metastasis from stage 1 to stage 3 is from 7% to 27%, and para-aortic macrometastasis in patients with local advanced cervical carcinoma almost 22%, as you see here. And FIGO versus Tnm staging system. Accuracy of Tnm staging system, as you see, is stage by stage. And the most important thing is upstaging 25 to 67% when we use Tnm staging system. Martins published 2005. If tumor involvement of lymph node is defined as a higher tumor stage, only 13% of patients in our study remained in their original FIGO stage after laparoscopic and histopathologic evaluation. And recently, the revised FIGO classification is now more closely aligned with the Tnm classification in this respect as well. And this is the revised FIGO staging. You see here, according to the lymph node metastasis, pelvic or para-aortic lymph node metastasis, 3C1 or 3C2. And we have to look the footnotes of FIGO staging system, and you see surgical assessment of para-aortic lymph nodes may be used to the tailored treatment according to the extent of disease. It is very important, tailored treatment. And surgical exclusion of para-aortic lymph node involvement has been reported to have a better prognosis than the radiologic exclusion alone. This sentence is very important, and a review of 22 articles that assess the safety and impact of pretreatment para-aortic lymph node surgical staging found that 18% of the cases has para-aortic lymph node metastasis. From 1997, my institute started surgical staging for local advanced cervical carcinoma cases, and we performed laparoscopic or robotic extraperitoneal para-aortic bilateral common iliac lymph node, and if it is negative, external pelvic chemoradiotherapy. If it is positive, if capsular involvement is positive, supraclavicular lymph node sampling. If it is negative, extended field radiotherapy. If it is positive, only palliative care. The anatomy of supraclavicular lymphatic lymph system is not hard. It is very easy. All gynecological oncologists can perform biopsy from inferior deep cervical lymph nodes, as you see here. And this video presented by, as I said, Fatna Al-Khan. She had edited after the operation robotic extraperitoneal lymphadenectomy. You see, we use air seal system. Air seal system stable the carbon dioxide pressure, and as you see, we are opening the spaces first of all, and garrota fascia is over there. And left ureter, left common iliac artery, and presacral area. You see there's a huge bulky lymph node over there. We will start the para-aortic lymphadenectomy, and to see the anatomy, we are starting from the common iliac artery's left side, and we have to reach to IMA. You will see just now. Right common iliac artery over there, you see. Right common iliac artery, left common iliac artery. Now we reach the base of the IMA, and after that, as you see, my colleague Abdulaziz presented minimally invasive surgery is a good chance for gynecological oncology. As you see, the robotic arm is turning like a hand. And I'm dissecting the IMA. I am removing the lymph nodes here. As you see, this is the IMA. And after starting from the IMA based, lower para-aortic lymphadenectomy from the left side of the aorta. Don't worry, we will reach the right side of the aorta and right side of the vena cava inferior. As you see, bifurcation of the aorta here. We reach the bifurcation. We are separating the lymph nodes, aortic, para-aortic lymph nodes from the common iliac lymph nodes. We will remove separately. And now I'm going to the right side of the case. This is the fallow vein. I cauterized and collected, harvested the para-aortic lymph nodes and removing in an endobag from the 15 millimeters air sealed trocar. And now left common iliac lymph nodes, I am dissecting. Deep common iliac lymph nodes just now. You see over there lumbar 4, artery and vein. We harvested the left side, and now I'm going to right side. You see here right common iliac artery and right ureter. And now you will see the right ureteral vein. I'm cauterizing. Okay, cut. And after then, presacral area, I'll remove this bulky lymph node. And again, in an endobag, we will remove all the lymph nodes from the 15 millimeters air sealed trocar. You see the anatomy after the operation. You see IMA over there. We'll show you just now. Okay, IMA, aorta, vena cava. We are using hemostatic powder after the operation for little bleedings, and we have to open a window at peritoneum, avoiding from the lymphocyst. And let's go to endometrial cancer. Previously, my colleague presented endometrial cancer risk factors and the prevention, and this is the Mayo Clinic's data. As you see here, only one red ball is at risk, and 12 to 15% of the cases positive lymph nodes. And according to Mayo data, if the myometrial invasion less than 50% and grade 1, we don't wait any lymph node invasion. And because of that, Mayo announced that no need lymphadenectomy group is endometrioid, his histopathology, grade 1 and 2, myometrial invasion less than 50%, tumor diameter less or equal than 2 centimeters. If there is no myometrial invasion and the histopathology endometrioid type, independently grade and tumor diameter, it is not necessary performing the lymphadenectomy. This is our lymphadenectomy indications, my institute's lymphadenectomy indications we published in 2011. Grade 2 or 3 tumors, myometrial invasion equal or more than 50%, tumor diameter more than 2 centimeters, adnexial metastasis, presence of cervical involvement, high-risk histopathology, as you see. This is the traditional lymphadenectomy indications. I'll show you the recently our policy. And Mayo Clinic, again, announced that non-endometrioid, no gross disease cases have only less than 5% isolated paraortic lymph node metastasis, and Sloan Kettering announced that it is only 1.6% isolated paraortic lymph node metastasis. Because of the systematic lymphadenectomy morbidity, short-term morbidity you see over there, and long-term morbidity, lymphedema, lymphocyst, fistula formation, nerve injury, pain, and sexual dysfunction, we are focusing on sentinel lymph node biopsy. The sentinel lymph node is the first lymph node that received the drainage directly from the primary tumor and is therefore useful in detecting lymph nodes with the highest metastatic risk. This interest in sentinel lymph node biopsy in relations to gynecological cancers are logical because early stage of cervical, endometrial, and vulvar metastasis primarily to lymph nodes. This is the schema of the sentinel lymph node. As you see, tumor cells metastasis primarily to the sentinel lymph nodes, after then the distant lymph nodes and organ metastasis. And universally, the most common region where sentinel lymph node were detected was around external iliac vessels and in the space between external and internal iliac vessels. The latter called interiliac, supraobturator, or obturator fossa in different papers. These two main regions encompassed between 65 and 85% of sentinel lymph node locations. These are the injection sites for sentinel lymph nodes. We use as this from the 3 and 9 o'clock ICG injection. You can use isosulfan blue, methylene blue, lymphoscintigraphy, or indocyanine green. If you use indocyanine green, you need near-infrared imagers for open surgery, for laparoscopic surgery, or robotic surgery. We use pinpoint system for open and laparoscopic surgery, and Firefly mode, as you see here, robotic surgery. And when we look this publication, you see the group 2 is ICG group, and bilateral detection rates is very high when we look compare with the radiocolloid and dye blue. And the rate of successful detection of sentinel lymph node in hemipelvis was 90.9% if mapped with ICG, but only 64.4% if mapped with blue dye. The use of ICG instead of methylene blue dye results in a 26.5% increase of proportion of hemipelvis with successful sentinel lymph node detection in women with endometrial cancer. False negativity is the most important issue. Canadian consensus announced that false negativity is 5%. It is very good end. And Mayo Clinic works with frozen section and sent the frozen section sentinel lymph node. If it is negative, you don't need to perform systematic lymphadenectomy. If it is positive, systematic pelvic lymphadenectomy. But Memorial Sloan Kettering group doesn't work with frozen section. They are sending the sentinel lymph nodes for ultra staging. If ultra staging negative, no need to adjuvant treatment for low risk cases. If positive, adjuvant treatment. We are following the Sloan Kettering group's algorithm recently, and this is the sentinel lymph node mapping with SPY for open surgery. As I said, we used pinpoint system. As you see, after injection from 3 and 9 o'clock of cervical injection, 0.5 millimeters deep and 0.5 millimeters submucosal, and you can see the lymphatic channels, and over there, sentinel lymph node. This system has a very nice system, as you see, color segmented fluorescent system, and these two hot areas as the sentinel lymph nodes. You can see the sentinel lymph nodes easily with this system, and you have to dissect and resect this two sentinel lymph nodes. This is the open surgery, and I want to continue with the laparoscopic surgery. For the laparoscopic surgery, we are using the same system. And after the opening retroperitoneum, as you see, you can see the lymphatic channels, green channels, and we are looking for the sentinel lymph node. There is a lymph node over there, but it is not sentinel, as you see. It is not green. But under this lymph node, you see the sentinel lymph node is over there at the obturator fossa. And you can't see naked eye, as you see. You have to use near-infrared imager. It is very important, and we are dissecting the real sentinel lymph node, and we will send for ultra staging. And if we continue with the robotic surgery, this is the end of the laparoscopic surgery. You have to careful over there for the obturator nerve, as you know, and obturator's artery and vein system. And when we continue with the robotic surgery, again, Fatma had edited this video after the operation, robotic sentinel lymph node biopsy. Unfortunately, in robotic system, you can't use the colored system. You can see sentinel lymph nodes only grayscale. As you see, naked eyes, you can't see anything. And after firefly mode, we will see the lymphatic channel over there, lymphatic channel. When we follow the lymphatic channel, we will find, yes, we found the sentinel lymph node, and resecting, dissecting, and sometimes firefly mode. We switch from firefly mode to normal mode because of little bleedings, and handmade endobag. We are getting the sentinel lymph nodes from the trocar, assistant trocar, and we will continue for the other side. As usual, open surgery or laparoscopic surgery or robotic surgery, you have to detect for both sides. If you can't detect sentinel lymph node, you have to perform pelvic lymphadenectomy for that side. For the ovarian cancer, this is the lymphadenectomy for early stage ovarian carcinoma. And if the ovarian cancer limited the ovaries, how about the lymph node involvement? As you see here, 15 to 25% of the cases have lymph node involvement. And how about the ipsilateral or bilateral lymph node involvement? 1/3 of the cases bilateral lymph node metastasis. This is the SEER data for the early stage cases, lymphadenectomy and no lymphadenectomy groups. As you see the survival, and you see the harvested lymph node numbers. If you harvest more than 10, the survival rates will increase. And how about the advanced stage epithelial ovarian carcinoma? Debulking is the main issue. Advanced stage epithelial ovarian carcinoma. If you reach maximal debulking, no residual tumor or RSFR in another term, 10 years overall survival, 60%. If you reach optimal debulking, equal or less than 1 centimeters, it is only 30%. If you cannot reach optimal or maximal cytoreduction, there's no survival expectancy. Because of that, you see here from Germany, they published harvested lymph nodes are important, as you see here, but the more important thing is lymph node ratio. Metastatic lymph nodes, harvested lymph nodes ratio. And according to this, these are the survival graphics. This is a very good case. We performed this case again, Fatma. And there, as you see, there's a huge metastatic retroperitoneal lymph node. If you don't remove, this is the same case, after removing that lymph nodes, you can't reach maximal cytoreduction. And CCN again, the last version of the ovarian carcinoma recommends lymph node dissection for the advanced stage ovarian carcinoma. This is an important study, LION study. LION trials showed us there's no difference for the lymphadenectomy performed or not. This is the graphics for progression-free survival and overall survival. But footnotes are important, as I said. You have to look the details of this trial. If clinical positive nodes were present, you can exclude the cases, and to evaluate the lymph node status, it is recommended that retroperitoneal space be opened from the inguinal ligament to the renal vein. You are preparing all the spaces for lymphadenectomy. If there were any nodes that appeared macroscopically to the surgeon to be involved with tumor, the patient did not fulfill the eligibility criteria, and further treatment was performed according to local standards. And survival contribution of lymph node dissection. In another study, lymphadenectomy has better cause-specific survival at the maximal debulking group. And at discussion, lymph node involvement in epithelial ovarian carcinoma is a poor prognostic factor. The patients with epithelial ovarian carcinoma who had lymph node metastasis have lower disease-free overall survival is controversial. 1/3 of lymph node metastasis is microscopic. The complications of lymphadenectomy are acceptable. Adjuvant treatment in patients with tumor limited to the ovaries is planned according to the lymph node involvement. The last cancer is vulvar cancer we have to discuss. Radical changes of treatment on vulvar cancer for the last 40 years, operation regarding in the lesions, approach to lymph nodes, and radiotherapy indications. These are the anatomy of groin, and this is the lymph node positivity areas of groin, and no need of inguinofemoral lymphadenectomy if stromal invasion equal or less than 1 millimeter. Ipsilateral inguinofemoral lymphadenectomy at lateral tumors. And how about pelvic mapping. This is the mapping for vulvar carcinoma. We used isosulfan blue and tracer technetium-99, and we found the lymph node, as you see here, and lymphatic channel. This is my last slide. How about pelvic lymphadenectomy for the vulvar cancer? Indicated the presence of lymph node, 2-year survival with positive lymph node. As you see, external pelvic radiotherapy group better than the lymphadenectomy group. Shukran again.
Thank you, Professor Kosa, for the very comprehensive presentation. We have the time for one question only. No questions?
Dr. Farouk, I just want to ask you, with your experience of using these, during the sentinel lymph nodes, I mean, during the surgery, did you find that it is difficult to recognizing the anatomy after applying the sentinel lymph node?
It is very easy detecting the sentinel lymph node if you use ICG, and if you have near imagers, infrared imagers, it is very easy. But it depends on your equipment.
The anatomy, I mean, it will not be like, you know, if you're doing it will be a mess, or you will not differentiate which is which.
This question is very important question, because it depends on the tumor size. For example, cervical carcinoma, if the tumor is more than 2 centimeters, unexpected sentinel lymph node is very high. But less than 2 or less or equal than 2 centimeters, it is normal. You can find, as I said, external iliac artery and vein system or interiliac area. For unexpected sentinel lymph nodes, you have to check the lower paracervical trunk pathway. Because of that, presacral area is the most important unexpected area site.
Thank you.
Okay, we came to the conclusion of our second session for today. I would like to thank all our 4 speakers for the nice intellectual lectures. And this is now for the lunch break. And we have to be back again, inshallah, at 2:30. Thank you very much.